What if the way you've always managed dysphagia isn't the best way anymore? Join Dr. Phyllis Palmer and Erin Padilla as they challenge the status quo with a fresh, patient centered approach and share a practical tool to help you make smarter, evidence based decisions at the bedside. Don't miss it. Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Dr. Phyllis M. Palmer and Erin Padilla, a clinical SLP, and experts in the area of decisions in dysphagia management. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome, Phyllis. We'll start with you. Thanks so much for being here today. I'm looking forward to our conversation. Can you get us started by telling us a little bit more about yourself and how you are involved with dysphagia management?
Yeah, absolutely. Thank you, Sarah. Um, my journey in dysphagia started more out of necessity than design. As a young clinician, I was faced with many patients who had swallowing disorders, and honestly, was always kind of felt like I was flying by the seat of my pants. In my graduate program, there was no swallowing disorders class, and only it was only touched on slightly during one of my internships at the Boston VA. The only other option at that time was a program that Jerry Logeman had where she would go around the US and she had a intro and then an advanced swallowing program, and she would come for a couple days and do those. And she was an excellent mentor for many of us that go way back. Ultimately, my desire to better equip myself in the area of swallowing disorders motivated me to go for my PhD. Now I work at UNM, where I have the privilege of running a research lab that's dedicated to improving management of swallowing disorders. And the questions I was asking as a young clinician are still the ones driving me today. So thank you.
Fantastic. And Erin, welcome. Can you tell us a little bit about yourself and how you know Phyllis and why you care about dysphagia decisions?
Absolutely. Thank you for having us, Sarah. I'm an acute care speech pathologist and board certified in swallowing and swallowing disorders. I really enjoy dysphagia decisions of just how can we bridge the research gap. And I think my career sort of is emphasizing that of I volunteer in Dr. Palmer's lab. I first met her in 2012 as an undergraduate student at the University of New Mexico. She sparked my interest in swallowing disorders, and I've been a part of her lab since. With regards to caring about dysphagia decisions, I think the desire to implement evidence and bring the most up to date evidence and care to patients to assist them in making informed decisions and just having the best possible outcomes for them moving forward is so important. So, thank you for having us here today to talk about that.
Absolutely. Well, I thought maybe we could just start by talking about kind of big picture the world of dysphagia management in medical speech pathology. So, I'm an SLP who's been practicing coming up on 20 years now. And I have to say, I think things have changed a lot in dysphagia management, just in terms of how we talk about dysphagia, how we think about making our decisions in managing dysphagia. So, can you share a little bit from your perspective on what's happening with the big picture right now in dysphagia research and why clinicians might need to ask questions about their dysphagia practices?
Mm. You bring up an excellent point about how our field has changed over the past 2, 4 decades. And comparatively to other clinical medicine areas, the management of swallowing disorders is still relatively young. And so we've seen lots of developments in the management of swallowing disorders as a result of the dramatic increase in research and therefore our evidence base. We've seen it with respect to how the swallow mechanism works, how we manage swallow deficits and specific deficits, the potential consequences of swallowing disorders. In other words, it's not just about aspiration pneumonia, there's other things we should be thinking about. But thankfully, there's been movement away from, over this time period, from this sort of generic treatment responses like the chin down, thickened liquid for everybody, towards a more individually based function focused interventions. So we're embracing patient centered care more, where patients actually get to engage and choose how they want to manage their swallowing disorder rather than us as clinicians having kind of a one size fits all solution. We still approach treatment, I think, with sort of compensatory and restorative strategy concepts where the compensatory strategies provide support and hopefully improve safety for patients in end of life or while you're working with the patient to restore their swallowing mechanism. The difference, though, is that we now have a broader set of tools at our disposal, both compensatory tools and restorative tools. For example, for restorative treatment, we've seen movement towards strengthening and skill based training. Case in point, thanks to the work coming out of Dr. Trochet's lab, we're seeing interesting developments in cough skill training and other comprehensive management approaches. As far as assessment, there's so much to say about the last 20 or 40 years. As far as assessment, instrumental approaches are still the gold standard or to identify specific swallow physiology deficits, but the quality of video fluoro and the portability of fees and the measures that we can extract from these exams have both improved dramatically. In fact, when we started, we weren't doing, fees was a later comer.
Sure.
There's better standardization across procedures, across clinics. I look at the impact of MBS IMP from Bonnie Martin Harris's lab, or VASIS from Dr. Curtis's lab, the Digest from Dr. Hutchinson's lab, or the PAS from Dr. Rosenbeck and his colleagues. All of these things helped us develop standardization. And by developing standardization and clear protocols, we reduce variability across facilities and improve patient care. But also, those standardized approaches give us a way that we can have conversations together, right? Because we have a common vocabulary. The other big thing I'll say is there's a narrowing, and this is a part that's really exciting for me, between evaluation techniques used in the research lab versus those that are used in clinic, and a better understanding of how the specific measures we use in the research lab can provide direction for treatment. A good example there is Dr. Steele's aspect and now the newer aspect C, where the aspect is a measurement tool that you can apply to video fluoro and maybe fees too. Aaron, is that true? I don't know if that's
Just
true.
video fluoro.
Yeah. Just video fluoro to help clinicians identify underlying mechanisms leading to issues in swallow safety or efficiency. And the aspect C is sort of an easier approach that allows clinicians to also use these important measures. Another crucial transformation is our movement from reactive care to proactive care, right? We're getting better at anticipating risks rather than simply responding to them. In swallowing disorders, we need to understand the long term risks associated with a given specific swallow deficit for that given individual. And so there's two parts to what I just said. We have to understand the swallow deficit and what we can do to improve it, but we also have to understand the risks that are associated with that patient and or the treatment options we choose. So that's, I think, a place where we are fundamentally have grown a lot.
Yeah.
Um, and
I was
this
just gonna
evolution oh,
say I
sorry.
was gonna just pop in a sec. So you're like saying a lot of the great acronyms in dysphagia management, like Digest and Aspect C. And for our listeners, maybe we'll just kind of link those and include those in the handout in case they're hearing something that they're like, oh, I'm not sure what that is. So we can be sure to include that in the handout.
Yeah, Sarah, thank you for pointing that out. I apologize for acronyming.
Our whole world is acronym. That didn't bug me at all. Just like making sure if someone hears a new one, they can find it.
Yeah. I think, I won't go on too much more because there's so much you could say here. Um, but I think we need to ask ourselves, are we adequately considering the long-term implications of our recommendations, considering the risks, the potential iatrogenic impacts of our decisions? And there's lots of examples we could give. So, for example, while thickened liquids certainly have a place in our toolbox, What if the thickened liquids don't actually eliminate aspiration? Now our patients are aspirating materials that are harder to clear and more damaging to the lungs. So we kind of have to think more big picture because we know more, we understand better. Um, and we also need to ask ourselves, are we incorporating patient preferences and quality of life concerns into our decision making? Because ultimately, the most evidence based interventions in the world won't be effective if we don't align them with what the patient wants, right?
Right.
Um,
Absolutely.
I'll add one more comment and then stop here, and that is
Yeah.
so much. So you said 20 years, and I've been doing this for more than, I'm sad to say, 40 years.
Yeah.
Um, and, God willing, I'll see more changes in the future here. But I'm excited to see where we go from here because the interest is there, the technology is there. Hopefully, we'll get better understanding on what's the proper dosing. How do we handle sensory deficits better?
Yeah.
What about treatments for timing, more pediatric understanding, better understanding of risk factors? So I think we still have places to go.
Yeah, it's interesting, like, something that's jumping out at me hearing you explain all that is, there's kind of this cool double-sided coin where we've both gotten more standardized tools available, but that has allowed us to be more individualized with the treatment choices that we make for clients, which is really
Mhm.
cool, and then, um, the other point, which kinda leads into my next question, is just understanding how new dysphagia management research is in the scope of research. And so, of course, we're going to be learning things and shifting things. So,
Mhm.
here's my
Yeah.
next question. For some reason, it seems like, especially in the world of dysphagia conversations, um, when we talk about doing things in a different way, that sometimes it strikes a nerve with people. So I'm thinking maybe some of the info we're going to be talking about today might fall in that category. So I wondered if you had any words of wisdom just to prep me or the audience with a mindset to receive new information, and not feel defensive if we've been doing things that maybe you're going to say, we shouldn't be doing this anymore.
Absolutely. That's a great question, Sarah. And you're right that these conversations can lead to defensiveness. I think something to think about in clinical care is how things always evolve. So the one time standard of care at one point may be obsolete. So if we think about orthopedic injuries, for example, at one time for a broken arm, the standard of care was immobility and a cast for 6 to 8 weeks. But now the field of orthopedic medicine has evolved where sometimes patients with a broken arm will just be in a sling and they're encouraged to mobilize and prevent a frozen joint and so forth. So defensiveness, can come about if there's a new thought or a challenge or a change, but we can shift this mindset into a positive and a growth set mindset, a signal that there is growth potential to improve the care that we provide and very importantly to improve patient outcomes. I think that's why all of us, got in these help serving fields is we want to help patients, we want to improve the care of others. So, um, instead of seeing new information as a challenge or a threat, we can see this as an opportunity to become more effective clinicians if we evolve in our care. Growth can happen as we are on the edge of our comfort zone. We need to think about how can we facilitate these positive discussions? How can we do this maybe at an institutional level, at a local level, at a national level? At a local level, can you maybe have a journal club within your facility or your city, or things with your state association? Are there, grand rounds that you can have at your facility where maybe every couple months you talk about difficult cases and as a group, you think, okay, what could we have done better? What could we improve on? How can we grow? And then, of course, in today's day and age, the accessibility for continuing education events is so robust. This example of a podcast, when I first started my career, podcasts for CEUs were unheard of, so you can go on a nice walk and you're listening to the most up to date evidence. So there's just a multitude of opportunities to really help us to grow. But I think just reminding ourselves why we got into this field and remembering those early days when you're a graduate student sitting there with your eyes wide as can be, learning all the new and current things and so excited. If we can just continue to kindle that energy going forward, we can really make leaps and bounds in the care that we're providing and the growth that we have as a field.
Absolutely. And yeah, I like that you said that growth is right at the edge of the comfort zone because it is kind of uncomfortable to learn, like, oh, whoops, I think I need to do things a different way. But we all have felt that way. So just kind of normalizing, like, this is part of being in a profession where research is growing and shifting and shaping is really important.
It's a
So
journey.
I'm pretty excited to talk about what you two have put together today. You have used research to develop the Bolus framework. So, speaking of acronyms, right? The most perfect acronym ever, BOLUS. I love this framework because you have given us a tangible tool to make complex individual decisions about dysphagia management and really incorporate some of those holistic decisions about a patient's situation. Can you just start out by telling us about the Bolus framework and then we'll go through and we'll talk about each of the letters for the framework?
Yeah, thank you for your enthusiasm for the Bolus framework. And I think your comment really captures what we were hoping to achieve, and that is creating something that emphasizes that crucial shift towards individualized care, holistic care that we've been discussing. Of course, Aaron and I can't take credit for many of the components of the framework because this was built on the foundation of available literature from previous research. We have the groundbreaking work of Dr. Langmore, her 1998 study that helped establish many of the risk factors that we've included in the framework. And she made the case, and I remember as a young clinician reading this and just loving this sentence and have repeated it many times, but the gist of the sentence is that, sure, you need aspiration to get aspiration pneumonia, but aspiration alone does not cause aspiration pneumonia. And as a young clinician, that kind of blew my mind because I was always so protective of my patients who aspirated, right? Aspiration equals bad outcome. Well, guess what? Aspiration does not equal bad outcome, right? It's the presence of aspiration alongside those risk factors. Then there was the work of John Ashford, who tried to visualize some sort of a framework, and he called it the three pillar model, I think is how he would talk about it. But he limited it to the three pillar model for aspiration pneumonia. And he basically said you need several components. You need obviously aspiration, you need some sort of health issue, poor immune, general health concerns, and then you also need poor oral care. So he threw oral care on top of that, and and um, and kind of framed it as oral care being one of the main primary drivers for the risk of outcomes. So we had all this excellent evidence, but the problem was is even though we all had access to that evidence, it wasn't organized in a way that clinicians could really wrap their heads around it with ease. And so I think that's what the Bolus framework did is it took this acronym, as you said, um, and provided clinicians with a very easy to remember, because everybody can remember bolus, um, to allow them to kind of systematically checklist in their head, what are the risk factors? How many of these risk factors does my patient have, right?
Yeah.
So we broke it into 5 distinct categories, so each letter stands for a category. And I should mention that we're still kind of in the developmental phases here, and there's lots of places we can go. But each category has specific yes/no questions to help guide the clinical reasoning. Where B relates to bolus variables, O is oral care, L is lifestyle and ADL capabilities, U is unintended outcomes, iatrogenic kinds of things, and S is general system status. So, because we're in the developmental phases, we're kind of using this as a yes no checklist to help guide people. And Aaron and I have talked lots about that there probably needs to be specialized versions. So, maybe we need one for head and neck cancer where the bolus framework serves as the frame, and then there's extra things we need to address that are specific to cancer patients. Maybe that's true for stroke. Maybe that's true for degenerative disease. So, and then in addition to that, there might be disorder specific questions that are not currently being addressed. Um, we also need to think that maybe some things are more important than others. So there might be weights for some of these categories that we should be thinking of. So that's where kind of where we are right now.
And then just like on a practical level, is this like embedded in an article or where could people actually see the bolus framework?
Yeah, so let's see, there's one on Frontier, which is a freely available open source article. Uh,
Yeah.
Aaron, was that 24? I think it's 24.
2024, correct.
Yeah.
Yeah.
Called linking the it's called linking something.
Okay. It
I
has the word
forget.
linking in it. We will put it we'll put that article, make sure that's in our, references for the handout for the show too.
Okay.
So, let's go ahead and just talk through the framework, and so just kind of helping shape the clinical decision making here. So, we will start with B. B for bolus variables. Can you talk to us what is in, what is out in dysphagia management when we're thinking about bolus variables?
Thank you, Sarah. So, one may ask themselves, is all aspirated material the same? If the patient aspirates thin and thick liquids, but the amount of thick and liquid aspiration is less, is it better? Or is there less risk of an adverse event by putting this patient on thickened liquids because less is going into the airway? Well, let's dive into things and discuss that. First off, not all aspirated material is equal. Things that are thick and dense are going to increase the odds of an adverse event if other factors specific to the host are present that we'll discuss in greater detail today. Solids are going to be the most difficult to clear from the airway, and in fact, if aspirated, can increase the odds of an airway occlusion. Next, thickened liquids are more difficult to clear from the airway, either through mucociliary clearance, which are small cilia fibers which are microtubule-based organelles, or through spontaneous or reflexive coughing. Water would be the most benign if aspirated because of the near-neutral pH and the engagement of the aquaporin ion channels to clear the water. With regards to aspiration of water, consider the patient that maybe has a bronchoalveolar lavage where they're essentially washing out the lungs with sterile water and water is instilled directly into the lungs. Why do these patients not have an iatrogenic pneumonia? Well, one idea is because the water bypasses the oral cavity and any bacteria laden contents, and then the further various defenses of the pulmonary system, such as mucociliary clearance or aquaporin engagement. When discussing aspiration, we have to think about the immigration and elimination cycle. There's a continuum of airway protection that was proposed by Dr. Trochet and colleagues. And along this continuum, you have swallowing, laryngeal adduction reflex, expiratory reflex, and effort, cough or throat clear, as well as, and these would be known as the primary defenses. If
Mm,
these fail, there are secondary defenses in the lungs that we just discussed, mucociliary clearance and aquaporin channels. And if there's a secondary opportunity for infection, the more frequent amounts of aspiration and the larger amount of aspiration, in theory, could result in a greater likelihood of an adverse event. And on that note, so we've talked about frequency and amount and density. Depending on the type of thickener, if aspirated, this can actually cause histological damage to the lungs. And there's a lot of work by Dr. Nativ Zeltzer looking at an animal model of the contents of aspiration, thin versus thick, water versus xanthan gum or starch-based thickener, and the damage that occurs to the lungs. We also want to think about acidic material. So this work was done in the early 2000s from Dr. Paul Merrick about the differences between aspiration pneumonia versus chemical or aspiration pneumonitis. So that's more of aspiration of gastric contents. There's going to be a greater insult to the lungs if acid-laden contents are aspirated. For example, aspiration of vomitus can sometimes result in a rapid decompensation of the patient's pulmonary status because of the acidity of the contents that are aspirated. So, eating and drinking wise, this can still occur if someone is frequently aspirating acidic things such as tomato juice or orange juice. And we can't have a discussion of aspiration without talking about silent aspiration, and in that context, talking about a weak cough as well. So, if we think back to the continuum of airway protection, as well as the immigration and elimination cycle of things immigrating into the airway and being eliminated either through primary or secondary defenses, if the aspiration is immigrating in silently with no cough, the primary defenses were likely unsuccessful. So, next up would be the secondary defenses, and maybe defenses are diminished because of acute illness or maybe chronically. Think of the patient in the ICU on high flow nasal cannula who's immunosuppressed chronically because of organ transplantation, but then also acutely because of high dose steroids attempting to reduce the inflammation. So, this would be a prime condition for an opportunistic infection. So, dystusia would be better than atusia in this case. Um, but we do need to think of some degree of, how can we modify this? For the hypothetical case that I just gave, are there various factors that we can modify in that acute time with engagement of the multidisciplinary team, as we know that the primary and secondary defenses would be diminished in that acute ill time?
Sure. So that was a lot of info. Very good. The things that I'm thinking about, kind of having my years of experiences, this is probably the most familiar part for SLPs in making decisions, like the bolus variables. But we have like learned a lot in the last decade or two of how to make these more like nuanced decisions and not just be like at all costs we're avoiding aspiration. It's really more about what you were talking about, the frequency, the duration, what the bolus actually is, and then looking at their defenses as well. Do you Aaron, I'm just gonna ask because 'cause you're working in acute care right now. How do you feel like SLPs in general are doing with this part of decision making? Do you feel like we're up to speed? Do you see like common mistakes that people are making?
Absolutely. I think it's a journey for sure. I think we're, growing in that aspect. And I think if we go in with an open mindset, an open book, and I think just the big thing is always have that learning, you always have your learning hat on. You're
Mhm.
willing to change, you're willing to grow. I do think that the field is moving more towards that direction of what are they aspirating? What is their cough like? So I think it's a journey, and we're walking.
Yeah.
But we can continue motivating. And I think just
Sure.
the folks that are listening to this podcast today, those are folks that are, how can I improve care? How can we,
Yeah.
move forward? So I think we're making progress little by little.
Yeah. Okay, before we go to the next question, we are doing something called the wild card question time. So, this is not on our planned list of questions. And Phyllis, we're going to start with you since Aaron just did all the talking. Do you have a favorite stress buster that you like to do after a long day of work?
Yeah, now you're gonna ask me to divulge this secret that I've
Oh, good. We like
protected
those.
for
No.
protected for many years, but here it's coming. I like to tap dance.
Oh my.
So, yeah,
If we
that's
had
what
a full body cam going, I'd make you demonstrate, but
Yeah, my grandfather was a great tap dancer, and so it's just a extension of the family honor or
oh,
something.
fantastic. Okay, Aaron, what about you? Do you have a favorite stress buster you like to do after a long day of work?
Yeah, I think, living in New Mexico, nicknamed the land of enchantment, we're just so lucky with all of the beautiful creation out here. So I think just, sitting outside the mountain range where Dr. Palmer and I live is called the Sandia Mountains, which is Spanish for watermelon. And when the sun sets, the mountains are watermelon red. So just sitting outside, hearing the birds sing, and just reflecting on what a gift it is to have this job and career, to go into a patient's life and help them and do the best that we can to get them back on their feet. So just reflecting on, even if things are stressful, it's just such an opportunity and gift to be in this field that we are in.
Absolutely. Okay,
Amen,
I'm
Aaron.
gonna put that on my travel bucket list to see those mountains too.
Yeah, it's beautiful.
Okay, we'll switch back to the bolus framework here. So moving on to O. O is for oral health and oral care. Can you talk about what's in and what's out for dysphagia management when we think about oral health and oral care?
All right. So, oral health and oral care. This really comes from, and I've already talked about Dr. Ashford before, but I'll say more about him. This really comes from his work where he illuminated this very nicely in his three pillars that I already talked about, where he said one of those pillars was oral health. that poor oral health creates a pathogenic oral environment. What's fascinating is that the oral cavity isn't just passively sitting there, right? When oral health deteriorates, it becomes this active disease producing factory. And we're talking about over 700 species of bacteria living in the oral cavity. And when things go wrong, when we have poor oral hygiene, periodontal disease, a lot of cavities, these normally balanced microbial communities become what we call dysbiotic, or simply go insane, right? In a healthy mouth, you might have about 3.6 million bacteria per swallow of saliva. But when someone has poor oral hygiene, we're seeing loads of like 189 million per milliliter of saliva. That's a lot of bacteria for the lungs to take on. It's not just a small increase, right?
Yeah.
So here's what really matters for our patients is every time someone swallows, which happens, I don't know, every 3 minutes or so during the day if you're healthy, you're potentially introducing the bacteria from the oral cavity if you have aspiration, prandial or microaspirations, which we all have. You're introducing those bacteria into the respiratory system. Um, so in healthy people, the microaspiration is normal and usually harmless because we have good lungs and we can handle it. Or we have good oral care and we don't have huge bacterial loads. But in our vulnerable patients, those with compromised immunity, those who are frail, those with swallowing difficulties, these become a pathway for serious respiratory infection. So here's where we as clinicians should and could do a better job, right? The
Yeah.
research shows that in nursing homes, less than one third of residents are getting their teeth brushed daily. In hospitals, oral care is the first thing to go off the list when you have a overworked nursing staff. Um, Yet here we know that proper oral hygiene can reduce pneumonia risks. It's been shown up to 40% in some populations. So when we look at O, we're asking ourselves three critical questions. Is there evidence of oral neglect or poor oral infection control? Because that means there's lots of bacteria. Does my patient have inadequate oral hygiene routines or a recent decline or change in their oral hygiene routines because now the bacterial load will increase?
Mhm.
Or does my patient have reduced saliva? Because there's also data that shows that when saliva is reduced, those bacterial uh, colonies can grow more.
Yeah.
So, the
The
cool thing though about oral health is that it's actually something we can do something about, right? It's a modifiable risk factor. So every time we properly clean a patient's mouth or help them learn how to properly clean their mouth or help support the nursing staff, every time we remove that bacterial biofilm from their teeth, we're actively reducing the risk of developing a serious complication.
Yeah. Now, that's something that the emphasis on that has changed a lot since I started, like, a couple decades ago, but, I think it's, like, obviously, it's so important, and it's also something that we don't have to feel like it's trivial to make sure we're doing oral care, setting up those oral care routines. I did want you to talk about a little bit something that's out a little bit, the swab situation. Can you get on a tiny little,
Yeah,
like,
yeah, sure.
tangent about swabs?
Yeah, so 40 or so years ago when I was in acute care, we had these things that looked like cotton candy, these pink swabs. And you would just go and just rub them around, and that was oral care. Um, and that does nothing. One, the sponge itself is not enough to debride the bacteria from the biofilm. Um, so then some people might have, so the swabs are bad, right? So don't, they well, not that
And
they're bad, they
maybe
just
they've
don't
been
really do
sitting
anything.
around for a long
Yeah.
time too in, like, the same cup of water. Okay. Yep,
Oh,
we got
yeah,
it.
that's
We got
yeah,
it.
even grosser, even grosser. Um, and then we started moving towards, well, if the brush doesn't if the pink sponge doesn't debride, maybe we could use more of a brush, and that's okay too, but when you brush the biofilm and you release it from the teeth, and then you don't rinse the mouth, now the biofilm's just hanging out in the mouth, right? So when I swallow and aspirate, I've given the system a gift of extra bacteria, which is hopefully not our goal. So now we know that we need debridement, We need rinsing, and we really need to work hard on keeping their oral cavities clean. When you're doing feeding in your therapy, it should always start with debriding of the oral cavity to make sure that we've gotten as much bacteria as we can. And I'm sad to say that the literature has leaned towards that professional cleaning is even better. So I think we need to think about when you're sitting in that dental chair getting your 6-month hygiene checkup or whatever, what are they doing to get your mouth clean? And be thinking sort of in that direction when we're cleaning a patient's mouth. The other piece is that, based on some of Langmore's stuff, that it's better when patients can clean their own mouth. So it's great to go in there and debride, but also part of it should be about helping the patient learn how to do it themselves.
Thank you. Okay, let's go to L. Is for lifestyle and activity level. So when we're thinking in that category, what's in and what's out for dysphagia management when we're thinking about an individual's lifestyle?
So we have three guiding questions for L. And first up is, does my patient have limited mobility or physical activity? Is the patient deconditioned? So we know the importance of whole body movement, and there's some early work by Dr. Ashwini Namasavaya McDonald looking into this. But I think something where we're still growing and learning is how much physical activity or how much mobility is important. So consider the patient that you're seeing that aspirates. Is one lap around the hospital floor enough mobility after they eat to try and help clear the aspirate? We know that generally outpatients have a less likely odds of an adverse event from chronic aspiration from Dr. Langmore's work as compared to someone that is in a rehab setting, long term care, or acute care. Or maybe just sitting at the edge of the bed. Is that enough? Since that elongates the diaphragm and that can help facilitate a more robust cough, an important aspect of the mucociliary clearance. So I think that's one area where we still need more evidence of how much, and that gets to the dosing piece that Dr. Palmer was talking about earlier. Our second guiding question is, does the patient drink or smoke with regularity? So, tobacco smoking reduces the mucociliary escalator and the secondary defense of the lungs. But positively, if the patient ceases smoking, then we would anticipate to see some return of the mucociliary clearance. With regards to alcohol consumption, this can impact the alveolar macrophage function. So, if you think back to high school or college biology and you have phagocytosis, where um, cells engulf foreign material, that occurs in the lungs. So, with chronic alcohol consumption, that can be diminished. And our last guiding question is looking at if the patient or client or consumer is dependent on others for activities of daily living, especially feeding and oral hygiene. As we chatted about a little earlier, folks may be in a care setting that are dependent on others. Sometimes these tasks may just not be completed, and that could be why there's a higher likelihood of adverse events. Or think of eating and drinking. Pacing may be different if a patient is being fed by someone else, or bolus volume, especially for liquids, may also be larger than a patient would typically consume. So those are sort of the principles we have at this moment for um, or lifestyle and activities of daily living. And a lot of
Yeah.
the data is gleaned from other fields, especially physical therapy with regards to mobility and importance of that for lung status and lung health. A large set of the data coming out of the ICU and looking at patients that are on a ventilator, those that are mobilizing compared to those that are not, are being extubated earlier or taken off the ventilator earlier than those that are, medically paralyzed out of necessity for their ventilatory needs and so forth. So hopefully, in the years to come, we have more robust evidence in that area.
Yeah, absolutely. And um, I know in kind of where I am in Michigan, we've kind of still moving with SLPs making decisions. Like we might have 2 patients, each with kind of the same bolus issues, but if one patient is in the ICU and was extubated a day ago, and one patient is at home and can drive himself to his gym, and, like, those are super different client profiles, really just based on the lifestyle, variables, but we would be free to make different decisions because of the way we can put all that, research together, so That's
But
great. So let's go ahead and go to U. So U is for unintended influences. Let's talk about what's in and what's out when we're thinking about unintended influences for an individual with dysphagia management.
Thank you, Sarah. Unintended influences are basically iatrogenic things, right? It's all about recognizing how our well intentioned medical interventions can sometimes inadvertently increase a patient's risk for aspiration or for pneumonia or other bad outcomes, right? So, our first question in that area is: does my patient have tubes in the oropharynx or airway? This is a common scenario, right? We place NG tubes, endotracheal tubes, all for very good medical reasons. But what we're learning is that these tubes are not just hanging out there passively, right? When you have a nasogastric tube, for instance, it can interfere with normal closure of the upper esophageal sphincter. It can reduce laryngeal sensation. It disrupts normal swallow mechanism. Um, there's evidence that patients with prolonged NG tubes actually have higher rates of pathogenic bacteria colonization in the oropharynx because bacteria can stick to that tube the same way the biofilm sticks to your teeth. So if we think back to O, if I have more bacterial content, I have an increased pneumonia risk if that is aspirated.
Yeah.
And then trach tubes, well, they completely change the anatomy and physiology of the airway, right? It alters the pressure differential. And because swallowing is a pressure driven event, that's kind of important. It alters coordination between breathing and swallowing. So you may see a change in the rate of aspiration or even the incidence of aspiration. Mechanical ventilation is also important. So the next question is my patient receiving mechanical ventilation? And this highlights really well an iatrogenic risk concept, right? We put patients on ventilators to save their lives. Absolutely the right thing to do. But ventilation itself creates what we call ventilator associated pneumonia, or it doesn't create, it creates a risk for what we call ventilator associated pneumonia, which occurs in about 25% of patients on ventilators. And then, of course, the endotracheal tube, which bypasses all the upper airway's natural filtration and humidification systems, can damage tracheal epithelium and provides also a direct pathway for oral bacteria to reach the lungs.
Mm.
These things are important. The next question is my patient on medication with side effects that impact alertness, cognition, immune function, or saliva production? And so this is kind of a huge question, right? Because we
Yeah.
rolled a lot in there.
Yep.
And I think we often underestimate the importance of all of these things that, um, there's lots of medications that affect alertness or cognition. And if I'm not alert and, or I'm sedated, I can't eat properly. So sedatives, opioids, anticholinergics, even certain antidepressants can all reduce a patient's ability to manage their secretions effectively and respond appropriately to aspiration events. There's medications that reduce saliva production, and nowadays almost everybody has allergies, right? There's over 400 categories of saliva medications that impact saliva. The biggest one, of course, antihistamines and decongestants, which so many of us are on.
Yeah.
When saliva flow decreases, we lose the natural rinsing and antimicrobial action, and again, it increases the bacterial buildup. And don't forget about medications that suppress the immune function, right? Steroids, chemotherapy agents, immune suppressants like patients who have been had a transplant. These reduce the patient's ability to fight off an infection. So it makes them more vulnerable if the aspiration occurs. So this takes us back to Langmore's sentence where, aspiration has to occur for you to have an adverse event, but it doesn't necessarily mean you have to have it. But if you're vulnerable, because your immune system is reduced, that's certainly a problem.
Sure.
And there might be, as I alluded to earlier, there might be more specific questions, iatrogenic issues related to different disease categories. So, like cancer, how much gray did you have in your radiation or that kind of thing. So,
Yeah.
yeah,
Absolutely. Yeah. I'm just kind of hearing permission to like take the individual situation and variables. I mean, those do impact the decisions we would make. So, let's talk about the last letter then. S is for system status. So, what's in and what's out in dysphagia management when we're thinking about system status?
Yeah, as we wrap up our final letter here, we have five guiding principles. And with that, think of, are these modifiable? Are these not modifiable? So, first up is the patient frail or deconditioned? So, frailty, these patients or individuals are going to have less functional reserve. So, maybe they're getting by okay, but then they get the flu and they're hospitalized for this, or they fall and they break their hip. So, because they don't have as much reserve, or think of reserve as sort of your backup power battery that you have. They may not be able to, ward off the aspiration that may have been chronic, or maybe because now they have something acutely going on, it's increased the amount of aspiration. And there's some ongoing work by Dr. Sonia Molfenter looking specifically at frailty and also looking at the role of, protein supplementation and so forth. Of just simply put, if someone is frail, it's going to be a lot harder to build muscle and rehabilitate the oropharyngeal system. We want to think about, does the patient have respiratory disease or GI disease? So this is going to be something that's more chronic. Respiratory system that has COPD is going to have a harder time clearing aspiration as compared to a healthy set of lungs, or the hypothetical case we talked about earlier of, the person that's driving to the gym and exercising every day. Does someone have GI disease where they're aspirating acidic contents, or their esophagus isn't clearing as well, and there's a higher likelihood of retrograde contents or solids coming into the airway? What about cognition? Is this something that is limited acutely by certain medication that is needed as a part of supportive care? Or is it chronic, where maybe the individual is living with dementia, and some of the factors such as oral care or oral hygiene or compensatory strategies that are needed to facilitate swallow safety and efficiency may not be deployed because of cognitive status? Or looking at immune function, is this something that, because of acute illness, think of high dose steroids, or maybe more chronic of current oncological intervention or organ transplantation? What are the different roles of the host and host defenses, and how can we discuss that with the medical team and the multidisciplinary team if we're uncertain if that's more chronic or acute? And then lastly, does the patient have a reduced cough response or reduced cough strength? So some degree of cough is better than no cough. And then just, when you're looking in your clinical toolbox of, maybe you have someone who silently aspirates, but, a tool that you can use, and we got this from our friend and colleague Lori Winterholm, of maybe having their do their EMST after they eat. Of, we're sending, things are going into the airway. They're not primarily defense wise coming out, but can we engage and modify that situation to where we're getting some degree of movement, where we can move things out of the airway, hopefully, after they eat and so forth. And that's Bolus. That's the tool
Yeah.
there. And our goal was to just give clinicians a place to hang their hat with something that's easy to remember. And I hope that the listeners find that true today.
Absolutely. Thank you guys so much for sharing like those key questions. We want to get in the routine of thinking through to make individualized decisions and really use our critical thinking when we're making those decisions. Um, if you think that there's probably some listeners who heard some new information today. So if we could just boil our chat down to the top 3 actionable takeaways for clinicians to put into practice, what would you see as the top 3, to make a clinical impact?
The first one you kind of just alluded to, and that is individualize before you recommend, right? When you're considering the best management plan, don't neglect to consider the risk factors specific to that patient and how your management plan can increase or decrease the risk factors for that specific individual.
Yeah.
Use something like the Bolus framework or develop your own systematic approach, but really look at the whole picture and incorporate the patient's status and the patient's voice into the clinical decision. The second one would be educate your patients, right? Because swallowing is not something they're doing only in your clinic room, right? So they need to have an understanding of what the risk factors are. So have real conversations with them about their risks and their choices. So we need to stray away from telling patients what to do and start educating them about the specific risks and letting them be the decision makers. So instead of saying you need to have thickened liquids, you try something like, here's what I observed during your swallow study. Here are the potential risks we're concerned about. Here are your options for those risks. Here are the trade offs of each one of those approaches. So, educating your patients on not only their swallow disorder and the treatment approaches, but the risks associated with their swallow disorders and the risks associated with the decisions they make. So, together with your patient, identify those things that are easily modifiable, and the patient can kind of wrap their head around that. Hey, I can't change the fact that you have COPD, but I can change the fact that brush your teeth when you wake up in the morning. Um, so that would be number two. And number three might seem like I'm overstressing this, but it appears based on all the literature that oral care is a big player here. So oral care should be, and because it's modifiable, it should be part of the things that you include when addressing your patients. Everyone has micro aspirations, so oral care is not just for people with prandial aspiration. Those would be
Absolutely.
my three. Aaron, do you have anything that you would add to that
Yeah,
list?
what I can think of is just reach out when you have questions. Of our world is so connected right now. Of an example today, Sarah, we're on different parts of the country, and we're having this call and engaging in discussion. Of maybe you're at a center where you have a specific population. Reach out to a researcher in that area that's doing a lot of that work. Of how can we bring the evidence to our clinics and centers and institutions and so forth. But even say at your center level of maybe you have a caseload where you have patients with lung disease, for example, very frequently. Set up a lunch and learn with the pulmonary team and just really how can we team up? How can we help each other to help the patients? I think are the big things. And the last thing I would say is just management of swallowing disorders. It's ongoing. You have a plan for someone that you're seeing in your outpatient clinic, and then something happens. They have a stroke, they fall, they get the flu, and it changes. It changes the plan. It changes the direction, and that's where I think the discussion with the patient is so important. Of just and maybe having those discussions up front. Say you're in a head and neck cancer clinic, for example, the patient's doing okay, but letting the patient know, ahead of time, we need to be proactive in these approaches because if X, Y, or Z things can happen, your increased odds of adverse events or risk or so forth. And really using motivational interviewing as a tool so we can help the patients achieve all of their goals that they set out for.
Yeah, something that's popping in my mind as you're describing your tips is just maybe SLPs could even just shift and shape how they're documenting, to kind of document in a different way of like, we're identifying the risks and like this is what was discussed with the patient. I feel like when I was doing a lot of this type of documentation in acute care, it was just all about like just the SLP like making the decision, but maybe there would be room to even
Mm,
build that into our templates and like how we're having that conversation. So, yeah.
I think that's such an
I like
important
that.
piece, Sarah.
Yeah.
And Dr. Paula Leslie has a lot of work on this, and something that I learned from her as a early clinician is in that documentation having this is what I shared with the patient. These are the questions that they had. Here's how they showed understanding. And here's the decision that we made together. And I think on that documentation piece, the important part is if we see a patient out here in the Southwest and say they transfer to you in the Midwest, Sarah, and you're reading the note should paint a beautiful picture, or even if you're not able to talk to the clinician, you know exactly what happened and exactly what went on, and that transition of care is seamless. So you
Yeah.
bring up an excellent point.
Yeah. Well, that's all some wonderful advice. Thank you both so much for joining me today, having this discussion. As we wrap up, did you have any final words of wisdom or inspiration you want to leave with our audience?
Uh, I think we said a lot of it, but I'll just say a couple more things, and that is, let's promote a culture shift from defensive to enthusiasm. So, when you hear yourself thinking, "But I've always done it this way," that might be natural, but I'm Aaron and I would encourage you to lean into that discomfort rather than resist it, and maybe retain a student spirit. Right, read the literature, commit to one article a month, not because someone's making you or it's for a grade or something, but because you're genuinely curious and you want to better serve your patients. Um, and then I think what Aaron and I have learned from each other is building bridges, don't wait for them, right? There's a gap between research and clinical practice. And if you're a clinician out there and you have information that you think is misrepresented in the literature or is absent from the literature, uh, start thinking about how you can help the field grow. Maybe reach out to a researcher and build a researcher clinician partnership. I think I'm a better researcher and clinician because of my relationship with Aaron, and so I think that there's a lot of opportunities for that across the country and across the world, and I'd love to see more of those partnerships. Um,
Absolutely.
and
Yeah.
yeah, so stay curious, stay humble, stay excited about the journey.
Awesome. Yeah, we certainly are better together. So thank you both for joining me today. Thank you, Phyllis. Thank you, Aaron, for sharing your insight and clinical takeaways related to making individualized decisions in dysphagia management.
Yep. Thank you so much. Appreciate
Thank
it.
you, Sarah.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. SpeechScope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.